Good evening, and thank you everyone for joining us today for today's Express webinar on Viz Subdural. My name is Meghna Valuri, and I'm a Senior Product Manager here at Viz AI. Before we begin, just a few housekeeping notes. Today's webinar is being recorded. If you have questions for our presenters, please submit them in the Q&A chat, and you can do that at any point, and your questions will be addressed at the end. If you have any technical questions, you can also use the Q&A chat function and we'll make sure to get back to you. There are 3 parts to our agenda today. So first, Dr. Arthur is going to present on the latest chronic subdural treatment strategies and trial updates. Second, I'm going to give a quick overview of Viz Subdural. And finally, we're going to answer questions from the audience. So it's my utmost pleasure to introduce Dr. Adam Arthur. Dr. Adam Arthur, a dual-trained neurosurgeon and endovascular neurosurgeon, is a professor and chair of the Department of Neurosurgery at the University of Tennessee Health Science Center. Dr. Arthur is a past president of the Society for Neurointerventional Surgery and the chair-elect of the American Association of Neurological Surgeons, the cerebrovascular joint section. Presently, Dr. Arthur is leading 6 multi-center international clinical trials, including the STEM trial, which focuses on utilizing embolization of the middle meningeal artery for effectively treating chronic subdural hematoma, which leads us, of course, to the topic of today. So Dr. Arthur, thank you so much for being here. Over to you.
Thanks, Meghna. Pleasure to be here. All right. So I think we have a lot in the audience who are part of the neurointerventional community in one way or another, and it's clear that this is a area of medicine that's going to grow. And so I'm going to talk particularly about MMA, EMBO for subdurals, but I really think that one of the things about this therapy that appeals to me is that we're a keystone. Arguably, if your health system or hospital is interested in cardiology, oncology, stroke, neurology, you need neurointerventional services. And neurointerventional services are quickly becoming one of these central fields because it's supplanting some of these other fields. I don't think aneurysm clipping and open surgery is going away anytime soon. This is Robert Spetzler walking through the halls after he clipped his last aneurysm, but it's not growing like endovascular is either. Here is a PubMed graph looking at endovascular by year showing dramatic growth. And while the market is very unregulated, this is from Anchorman, a hilarious movie where they have a gang fight. We know that thrombectomy indications are loosening, whether it's large core extended time window or low NIHS. And so there's an increasing burden for neurointerventional call that's challenging all of our systems. And so as we gear up to meet that demand, we need to expand ways in which neurointerventional teams can be used to combat other diseases. And these are some that I think are going to expand. So subdural hematoma therapy has been around a long time. Here's a classic sort of cookie cutter craniotomy, just like you might see in any of our hospital these days. But this patient was treated some 7,000 years ago based on radiocarbon dating. We don't know exactly why that craniotomy was done there, but it's a good chance that it was done to release the evil humors of a chronic subdural. So we've been doing things the same way for a really long time.
Who are you? Why aren't you masked? Who are these people?
I don't know.
What the hell is that? What are you doing?
Tearing of the middle meningeal artery.
What's your degree in? Dentistry?
How do you explain slow impulse, low respiratory rate, and coma?
Fundoscopic examination.
Endoscopic examination is unrevealing in these cases.
A simple evacuation of the expanding epidural hematoma will relieve the pressure.
My God, man. Drilling holes in his head's not the answer. The artery must be repaired. Now put away your butcher knives and let me save this patient before it's too late.
I'm gonna have you.
So obviously that was from one of the lesser known Star Trek movies. It's the one where they have to get whales to save the Earth from being destroyed. But I think it's funny that back in the 80s, there was this discussion about putting away drills because that's what's happening now. Chronic subdural hemorrhage is a disease that's on the rise, probably because we have older patients and more patients that are anticoagulated and antiplateletated, if that's a word. The VA cooperative study estimates that we're going to see over 60,000 cases a year before the end of this decade. And there's clear evidence from multiple investigators showing this rise in the incidence. Despite this, we've got a very heterogeneous environment here where different teams are treating this disease with different variants. I really feel like neurosurgeons are like the villagers who live on the slopes of a volcano. We've all developed rituals to try to prevent the disaster that we've experienced with this disease before, but none of these have been shown to dramatically reduce the risk of recurrence, which is somewhere between 10 and 20%. And they all involve taking older patients and subjecting them to invasive procedures and then having them lie usually flat in the ICU for a long time. These may be some of the reasons why, if you tell me that you have a patient with a chronic subdural hemorrhage, I can tell you that their chance of being dead in a year is somewhere in the order of 1 chance in 3. And that's why the World Health Organization has declared this a sentinel health event. It has been investigated. A variety of treatments have been investigated. None of them have really been a silver bullet. And so the entire premise of treating this disease from an endovascular route is based on the idea that this may actually be a vascular pathology. It may not just be leaking of blood. We think that's what's happening is that there's a vicious circle that's happening in your body where when there's any blood in that space, your dura grows these neointimal membranes that have capillaries that leak more fluid. And then those blood fluid breakdown products are fibrinolytic that causes more breakdown. And so you get into a vicious circle that can't be broken. And that may be one of the reasons why so many different treatments can break the circle, including just putting in holes. So if the continuous risk of fluid leakage, if that continuous fluid leakage exceeds your body's ability to absorb blood, then you can't fix this problem and the fluid accumulates. So instead of going in there and stripping these leaky membranes, which is invasive and carries its own risks, what if we could just decrease the amount of fluid that's absorbed so that your body can then fix this the way it's trying to? So this is a therapy that could be used as a standalone therapy so patients can avoid burr holes or craniotomy altogether. It could be used as an adjunct to drainage to reduce recurrence, or it could be used as a treatment for recurrence after drainage. And these are all avenues that are being explored. So I'm going to talk about these. I'm very excited about embolization as sole therapy. This is a part of my team here, some really tremendous individuals, one of whom is still at my center, and the other 3 who are all at academic centers around the United States. This is a patient we treated within the ongoing IDE trial. So they were treated with SQUID, which is a liquid embolic that isn't approved in the US yet. This patient presented with lateralizing symptoms, mass effect, and she here had angiography to show the course of the MMA. What we believe is that getting a microcatheter really far up so that you're not embolizing the middle meningeal artery, you're actually embolizing the pathologic membranes is very important. And you can see here the cast of those membranes. So you're not seeing just the arteries, you're seeing this sort of cotton wool membrane. And here's an injection with pulling back of the microcatheter to really fill those membranes. I'm not saying that you can't treat this disease by just embolizing the artery. I just believe that we can probably reduce the risks and improve the efficacy by getting distal up into the membranes. And I haven't proven that yet. I'm just telling you what I think. Here's a cone beam CT showing those membranes filled with liquid embolic. And one of the things that I've loved about this therapy is some of these patients get better dramatically, so quickly. So this patient woke up from the procedure with improvements in her headache, improvements in her neurologic deficits, and had CT that the radiologist read as normal, even though you can see there's still a little bit of gap there, subdural, within a couple of weeks. So unfortunately, in the STEM trial, we're not using Viz Recruit, but part of that is the trial is almost over. We only have, after Marcus Holtensbuter today randomized a patient in Nuremberg, we only have 6 more spots in the 310 patient trial, but it is being used in 2 extremely good competitive trials, Embolize, sponsored by Medtronic, and Membrane, sponsored by Cerenovus. And this is a tool that really allows sort of improved communication and facilitation of treatment and enrollment of patients into the trial. So there's a huge increase in the literature on this therapy. Here's a great paper run by the guys at NYU showing that you might be able to safely resume antithrombotic therapy more quickly after MMA embolization. Again, some of these patients are old, some of them have atrial fibrillation. That could dramatically reduce the morbidity and mortality associated with treatment of this disease. Maybe you don't have to stop it at all. This is something that multiple clinicians and investigators are looking at all over the world. Here's a paper by a multi-center group, a lot of stars you can see on this paper, showing that this can be a safe alternative or adjunctive treatment for older patients. And again, there are many more older patients now than there were 10 or 20 years ago. So this kind of experience in the literature obviously really increases our confidence that what we're doing is something that's very safe. So as an adjunct, it can reduce the risk of recurrence. This is a systemic review and meta-analysis showing that it's safe. And then that's probably why we're seeing a huge preponderance of a variety of different studies. These are all well-designed clinical trials that are going on in different parts of the world to investigate this. So I would anticipate that obviously in the next year, we're going to see really good quality evidence that lets us know how effective this therapy is, but largely the jury has sort of decided that. Recurrence, as I mentioned, is a big problem. Here's a great paper out of the Barrow group in Phoenix showing that this treatment can dramatically reduce patients returning back to the emergency room. We're all trying to help patients not to have to go to the emergency room. All of our resources are being stretched. And then here's another paper from Barrow showing a dramatic improvement in total hospital costs. No matter where we work, reducing hospital costs is something that's on all of our radars. So there's a tremendous physiologic opportunity, as I've outlined. I think we are beginning to understand this disease is not just about bleeding, and endovascular management could significantly accelerate resolution, reducing the need for surgery, reducing the need for emergency room visits, reducing reoperation, reducing the cost of care, eliminating comorbidities like patients having strokes because they're off anticoagulation, and maybe actually strike a blow against reduction in quality of life and independence for older people, which I think is a huge deal. There are more of these patients than AVM and ruptured aneurysm patients put together. As mentioned in the individual papers, this is a therapy that multiple investigators are showing significant improvements with. So it's a procedure that I think many people can be trained to do fast and safely. It is effective. And that's one of the reasons why you're seeing clinician scientists just in the last 5 years dramatically increase publication on this therapy. Here's another paper showing the nationwide trend. So obviously, if we're going to start talking about this, which we are and have, then people are going to start doing it much more. And we're already seeing that in administrative databases just in the last 5, 6, 7 years. Here's another great paper from Peter Kahn and some collaborators showing that MMA embo is associated with a lower need for surgical rescue. Just a quick note on complications. This is from the neuroangio website run by Max Shapiro and his colleagues at NYU. The biggest risks relate to inadvertent embolization from catheters that are too low. So you have to look at anastomoses with supply to the eye. You have to avoid embolic getting down towards the petrous bone. So again, I believe that distal catheter position and carefully getting really distal really helps to improve safety and avoid these anastomoses and avoid inadvertent embolization. So when does a new therapy become a standard of care? I think some would argue that middle meningeal artery embolization already is a standard of care. But we are going to have level 1 evidence on safety and efficacy, I think, within probably 12 months. And so that will meet an even higher bar for standard of care. So how about Viz for Subdural and Viz Recruit? You guys know how to do the embolization, or you have people there who can do it. What Viz can do is serve not just as a decision support aid, but as a treatment support aid. So it's going to dramatically help you to find these patients, increase referrals, figure out who needs this therapy, and get them in quicker, which could, based on the evidence that I presented, reduce hospital expenditures, and reduce pain and suffering for patients. So in conclusion, embolization of the middle meningeal artery for the treatment of chronic subdural or non-acute subdural shows great promise. There are multiple clinical trials. As I mentioned, the STEM trial, obviously I'm involved in that, is probably going to fill up in the next week, 3 weeks. And then we've just got to get through the follow-up. And this therapy can be employed as a first-line standalone measure, as an adjunctive treatment with surgical drainage, and as a measure after drainage to reduce recurrence or treat a recurrence. So I'll stop there just a little bit ahead of time. I'm happy to turn this over to Meghana, who's going to talk a little bit more about Viz and the Viz clinical product and Viz Recruit. Meghana, you ready to go?
Yes, I am. Thank you so much, Dr. Arthur. Okay, so next slide. So why Viz Subdural? The problems that Dr. Arthur just perfectly articulated is really what caused us to look into building a subdural product. He mentioned the growing aging population, the ever increasing volume of referrals, and we also just know that there are a tremendous number of broken communication pathways at hospitals today. And that's really why we built Viz Subdural. So a few things to know about this product, our commercial product. Viz Subdural is the first and only FDA cleared subdural specific algorithm. It detects suspected acute and chronic subdurals. It has both high clinical and economic value. And we offer comprehensive support for an optimized workflow in a plethora of situations across the hospital. This is the Viz Subdural product. So we use artificial intelligence to assess CT scans for subdural hematomas, both acute and chronic. The product then provides a filtered list of patients that you can scroll through that updates in real time every time there's a new detection. And all of these patients are those that have a detected acute or chronic subdural hematoma per the algorithm. Our mobile image viewer, which is known as best in class, takes you directly to the slice that best visualizes the pathology. And we flag the specific scan with the detection so that you can triage quickly. And then, of course, Viz also has comprehensive workflow features that allow the entire care team, everyone from nurses to neurosurgeons, to communicate in a HIPAA-compliant way. And we facilitate the management of directing patients for scheduling, for clinic follow-up, directly within the app. All of this, I should mention, is available to you on the go on your mobile device, allowing you to find the patients that you can help as quickly and efficiently as possible. At Viz, we also truly believe in the power of clinical research. This means that we ensure that we don't just see how our algorithms perform on internal data sets, but we also validate how all of our products and services perform in the real world. So in that vein, a recent study on subdural in a research setting and our Subdural Recruit research product showed that it performed exceptionally well on an independent validation imaging data set of 263 non-contrast head CTs. It had high sensitivity, high specificity, and a very high PPV. And this is primarily because we focus only on one type of bleed. It allows us to train and give you the best results because we know your time is valuable. We do this for all of our products, and Viz Subdural is a part of the larger Viz Neuro suite of products that gives you a comprehensive solution. We have Viz LVO for large vessel occlusion, Viz CTP, CT perfusion. We have Viz aneurysm detection, Viz intracranial hemorrhage detection, and now Viz Subdural. So I'll just conclude quickly so we can get right to questions. But I just want to leave you all with 3 key takeaways from this webinar. One, that the care coordination of subdural hematomas is a really incredible next opportunities for neuro teams to dedicate time to. 2, the new treatments are showing great promise for chronic SCH, as Dr. Arthur so perfectly articulated for us. And number 3, Viz Subdural, the first AI-powered solution for specifically SCH care coordination. Thank you all so much. We're going to open it up for questions. I'll bring back Dr. Arthur. Okay.
Hey.
So, Dr. Arthur, we have a question. So any thoughts about the risk of extension of embolic material into the venous sinus with distal catheter position?
Well, that's certainly a risk. You can create fistulae. I've certainly seen that multiple times between the middle meningeal artery and the veins. Unfortunately, if you do, you're not going to get very good liquid penetration into the membranes, but you can treat that very safely. Obviously, you have to be very careful and visualize what you're embolizing. So I really prefer doing these procedures under a general anesthetic. I know some people like to do these in awake patients. Obviously, you can avoid intubation. But if somebody's moving all over the place, it's really hard to see where the embolic is going. And I think, like much of what we do in neurointervention, you have to be precise. So theoretically, it would be possible to get into the veins, but unless you continue to push embolic into the venous system, a little bit of embolic in the vein shouldn't be a big issue.
Gotcha. Okay, perfect. Thank you. We also got another question about the use of MMA embolization for acute subdural hematomas. This person mentions that they've seen some enthusiastic practitioners using it for acute subdurals.
Yeah, so I'm aware that people are interested in this. I'm not aware of any evidence that it works. And I'm not sure that I understand how it works, but there are lots of things I don't understand. So I would think that's kind of a watch this space type thing. Like, we're going to have to see some reports and understand better in what circumstances that's safe. Obviously, patients who are symptomatic from acute subdurals are people who would be candidates for a decompression because they've got acute bleeding, and that's a traumatic emergency craniotomy type situation for some patients. So I would have to defer that until I understand better, when is that the right thing to do and when is it not? But I'm not aware of a good body of evidence that gives us a basis for doing that yet.
Yeah, absolutely. My takeaway is that there's just a tremendous amount of excitement about this particular procedure and its applications.
It's so funny because 3 or 4 years ago, when I was talking to people about this procedure, they thought it was crazy to do this at all. And now I'm having people say it's crazy not to do it. So it's amazing how fast things go.
Absolutely. Okay, so we had a clarification question. You mentioned the number of chronic SDH patients. They just want to clarify whether it's, you mentioned that the number of chronic SDH patients, I think, is going to be greater than the number of aneurysm patients and another population of patients combined. But the person just wanted to know, is that the number of chronic SDH patients or the number of MMA embolization candidate patients that's going to?
Yeah, great question. So that was simply incidence of chronic subdural compared to incidence of AVM and ruptured aneurysms. Those are baseline numbers that don't tell you how many should be treated, but it gives you an idea of the possible market size, which I think is large.
Yeah, the overall prevalence of the disease.
Yep.
Okay, perfect. Can you speak a little bit to how you think volume measurements of the bleed are going to be useful in the assessment of these chronic subdurals?
Absolutely. So, obviously within the skull, real estate is incredibly valuable and it's volumetric. And so as a treating neurosurgeon, I have seen people who have thin subdurals that are very symptomatic because they cover a large territory over the head and they take up more volume. So to me, it just stands to reason that volume is going to be an important tool for us to understand, when somebody has a greater chance of benefiting from a treatment of their subdural. But that's just not, again, that's something we're going to learn. My understanding is that volume is available in Viz Recruit, but not available in Viz Subdural just yet. But I fully expect that there's going to be papers out there that look at thresholds of volume for, when somebody is going to potentially benefit from this procedure.
Yeah, absolutely. It's a super interesting update in the assessment. And I think we're very interested in that at Viz, and that's why it's available in our research product right now. Okay, lots of questions. So are particles effective short and or long term is a question.
Well, so when we started looking at this with liquid embolics, particles were the mainstay of treatment. And so I believe probably almost anything might be effective. I mean, as I said, my current understanding of the theoretical basis of this disease is that if we can reduce blood flow to these membranes, you probably have a good chance of helping the patient. I am aware of several patients just in the last year in the United States who have been blinded, sometimes by very good neurointerventionalists using particles, because you don't always see where the particles are going. Now, somebody's going to raise their hand and say, look, I've been using particles for years and I've never had a complication. Great. So yes, I think particles probably can be effective. I just personally, I have my biases. I like asleep patients. I like distal catheter position, and I like liquid embolic, and I have arguments why I feel that way.
Yeah, that makes sense. And on this note of the complication of blindness, we got another question. How often have you come across facial palsy and blindness as a complication of MMA?
You know, I am knocking on wood. That has not happened during my tenure at my current position, and I've been here almost 20 years at my center. But again, it could happen to us tomorrow. You're only as good as your most recent case. And again, I know good neurointerventionalists who have had, probably through injuring the vasa nivorum and getting embolic, whether it's particle or liquid embolic or whatever, to the facial nerve or to anastomoses that go to the eye. So these are inadvertent embolizations, just as the question about the vein, that you need to watch. And again, that's one of the reasons why I like an embolic that I can clearly see in a patient who's fully asleep, because I'm a little bit of a control freak about making sure I know what we're treating and avoiding, embolizing something I don't want to embolize. Yeah,
absolutely. You mentioned in your presentation about recurrence rates and how MMA has possibly been shown to reduce recurrence rates. Have you seen any trends in other hospital measures of success, like length of stay or readmission, any other quality of life metrics? I think you touched on it.
Yeah, no, I mean, so for the two that you mentioned, which are emergency room bounce backs and length of stay / hospital costs, again, I would point to the group at Barrow, who have published peer-reviewed papers on this. So I think that evidence is in the literature. I have not looked at it at our centers, but I don't see any reason why that wouldn't be true. Certainly anecdotally, it's true.
Okay, we got another question. Is MMA embolization for only non-traumatic chronic SDH and or also for recurrent SDH where the original injury may have been related to trauma? So I think it's a question around trauma and.
Yeah, I think it's a great question. So, our understanding of how subdurals form is something that's evolving. And so the questioner is asking whether the etiology, the initial eliciting event matters, if I understand the question correctly. And I don't think it does. I mean, to some extent, whether somebody's really old and a bridging vein leaks versus there was a car accident or a trauma, what seems to happen is you get into this, feedback loop where your body attempts to heal that injury by growing in these membranes. And for the open surgeons who've done treatment of chronic subdurals with craniotomy, the membranes are really weird. I mean, they almost look like an infection sometimes. They're sort of these crappy, brown inflammatory things. So I think my understanding is that it's your body trying to heal that space, and the injury to that space could be trauma, or it could be, something that is not technically traumatic. In any case, you end up in a situation where there's this exudative fluid that's coming out of these abnormal neocapillaries, and your body can't absorb it. So there's some great papers in the literature that show growth in the middle meningeal artery in patients who have chronic subdurals for a period of time. So it's sort of something. I mean, if you will, it's almost like a fistula, right? There's increased arterial flow into that space, and your veins can't keep up. So I don't think it matters whether there was a true trauma or not that started it. Now, this goes back to the other question, can it be used as a treatment for an acute subdural?
Yeah.
I don't know. That may be a bridge too far at this point, but I know people are looking at that.
Amazing. Okay. Okay. And then thank you so much. So there's just one more quick question that I'll address. How does vis subdural differ from vis ICH? Why do I need vis subdural? I can take this one, Dr. Arthur. I know you touched on it briefly, but vis ICH detects only acute intracranial hemorrhages. So it's not going to detect these chronic subdurals that we spent this whole talk talking about. And also because vis subdural was only trained on subdural hematomas, both acute and chronic, it has a much higher sensitivity and specificity than vis ICH for the acute subdural subset. So it's an incredibly valuable product, and we're really excited to see how it continues to impact people in a hospital setting. Okay, we are at time. Thank you everyone so much for all of these open questions, for all of your questions. If you have any further, please feel free to contact the Viz team. And Dr. Arthur, thank you so much for your time and for talking to us today about all the incredibly exciting treatments for chronic SDH. We can't wait to see what comes next.
Well, thank you to Viz, and thank you to the audience who tuned in. I've been getting a couple texts from friends who tuned in, so thank you guys for wanting to listen to me rant. See you guys all soon.
Thank you, everybody. Take care.